It is my pleasure to present Professor Dr. Wael Lotfy, Professor of Pediatric and Pediatric Cardiology. He will present supraventricular tachycardia in children when to refer to EPAC.
Bismillah ar-Rahman ar-Rahim. الحقيقة thank you very much for البرزنتيشن اللي ما استاهلوش. Supraventricular tachycardia in children was my first introduction to the arrhythmia arena with the idea from Professor Fadia Mahmoud, my professor, to communicate with our adult colleagues, Professor Sharif Mukhtar, the professor of my professors, and Professor Hassan Khalid, who were overviewing me in my master and in my MD thesis, which continued in arrhythmias. Coming back to our topic, since the dean is coming at 10:30. I will discuss briefly, in simple terms, not in complicated terms, the indications to refer supraventricular tachycardia to the EP lab or to the EP specialists. Diagnostic indications, interventional indications, pacing indications, and considerations before referral. The most important thing to remember is that a child is not a small adult, because we commonly refer, particularly in private hospitals, whenever a hospital does not have a pediatric cardiologist or even a pediatric arrhythmologist, the common formula for treatment is referring for an adult pediatric cardiology, asking for the medication that they usually give, and then looking for the dose for this child and giving this medication regardless of anything else, regardless of the diagnosis, regardless of if it's beneficial or not, natural history, things like this. So please remember that a child is not a small adult. My discussion today is based on the European Society of Cardiology guidelines for management of patients with supraventricular tachycardia. The reference is there. The most important summary that I can convey to you, first of all, we need to consult. Whenever we see, even myself, my colleagues, whenever I see something I'm not used to, I consult. I consult locally my colleagues, I consult overseas to ask if somebody has seen this before, does he know the natural history, the prognosis, before doing anything. It's usually very important to think, diagnose before acting, not to move into doing things. I have seen in the ER sinus tachycardia patients 1 month, 2 months receiving repeated DC shocks because they were diagnosed as SVT. So before acting, particularly if the patient is hemodynamically stable, think, consult, ask. And of course, if everything is stable, you can always refer. And it's about evidence, not about logic. The key messages from the European Society of Cardiology guidelines were that the amiodarone and digoxin are no longer mentioned in the new guidelines for acute management of narrow complex tachycardia. Sotalol and lidocaine have been removed from the acute management of wide complex tachycardia algorithms. Despite we are not doing this, but they recommend not to use sotalol with supraventricular tachycardia, secondary to the pro-arrhythmic effect of it. They do not recommend using flecainide or propafenone in patients with left bundle branch block or ischemic or structural heart disease. Do not use amiodarone in pre-excited atrial fibrillation. 1 in 5 patients with asymptomatic pre-excitation will develop an arrhythmia related to their accessory pathway during follow-up. So seeing a pre-excited patient, even if he's not symptomatic, should make us consider intervention, even if he's not symptomatic now. The risk of cardiac arrest, ventricular fibrillation in a patient with asymptomatic pre-excitation is 2.4 per 1,000 person years. Multiple drugs have been removed from the acute and chronic management of inotherm reentrant tachycardia. Verapamil, diltiazem, and beta blocker remain as options for the chronic management of AV nodal reentrant tachycardia, but they were downgraded from class 1 to class 2A. Diagnostic indications, in simple terms, whenever you're not sure of the diagnosis, whenever there is a possibility of something more dangerous than a simple SVT. Non-invasive screening may be used for risk stratification of patients with asymptomatic pre-excitation, but its predictive ability remains modest. Invasive assessment with EP is recommended in patients with asymptomatic pre-excitation who either have high-risk occupations or are competitive athletes. If the arrhythmia is significant and the diagnosis cannot be established otherwise, for example, the differential diagnosis of a wide complex tachycardia, SVT versus VT, suspected serious substrate like the Brugada syndrome, the Ajmalin test, things like this. Both invasive and non-invasive tests are for the risk management of patients with asymptomatic pre-excitations have limitations, being dependent on the autonomic tone. We are aware of cases, and we have seen cases presented where a pre-excited normal child have been taken to the EP lab and decided to be safe accessory pathway, and he's doing extremely well. And then to see this same child after 6 months, after 1 year, coming with AF converting to VF in the ER, even after the EP lab was completely safe. So you have to think of this. The proper management of asymptomatic pre-excitation and strict catheter ablation indications have not been established. The genetics of SVT have not been adequately studied. There have been evidence for familial forms of AV nodal reentrant tachycardia, AV reciprocating tachycardia, sinus tachycardia, and atrial tachycardia, but data are scarce. The ablation indications, if we can speak in short, it will be any patient that is 4 years, 15 kilograms, with a supraventricular tachycardia. The first choice is EP and ablation, electrophysiological testing and radiofrequency ablation. This will be the first choice for him. But coming into more details, the first indication would be symptomatic recurrent supraventricular tachycardia due to AV nodal reentrant tachycardia, WPW syndrome, unifocal atrial tachycardia, atrial flutter. For these indications, catheter ablation is first line. And according, of course, to the patient's choice. But for us, it will be a first-line therapy. The second indication is atrial fibrillation with lifestyle impairing symptoms and inefficacy or intolerance of at least one antiarrhythmic agent. Both left atrial ablation for restoration of sinus rhythm and AV junction ablation for rate control are class 1 indications depending on the circumstance. The third indication is symptomatic recurrent VT. Catheter ablation is first-line therapy in idiopathic VT if that is the patient's preference. In structural heart disease, catheter ablation is generally performed for drug inefficacy or intolerance or as an adjunctive therapy with an implantable ICD who are experiencing frequent shocks that will drain the battery rapidly. Uncommon catheter ablation indications, according to European Society of Cardiology guidelines, are symptomatic drug refractory inefficacy or intolerance to with idiopathic sinus tachycardia, lifestyle impairing ectopic beats, they're very frequent and impairing the patient's life, symptomatic junctional ectopic tachycardia. Junction ablation for rate control are class 1 indications depending on the circumstance. Ablation is the treatment of choice for tachycardia-induced cardiomyopathy due to SVT. This particular indications, if refractory to medical treatment, is even indicated in the younger children. We usually try to avoid ablation below 2 years of age, but persistent heart failure, irresponsive to medications, is an indication. AV nodal ablation with subsequent biventricular or his bundle or left bundle branch pacing should be considered if the SVT cannot be ablated. Contraindications to catheter ablations, unstable patients. Relative contraindication are the patients who is less than 4 years, less than 15 kilograms. His risk is a bit higher. Few absolute contraindications to radiofrequency catheter ablation exist. Mostly apply to adults. Left atrial ablation, an ablation for persistent atrial flutter should not be performed. I again remind you that atrial flutter that presents in the first year of life usually responds to conversion of this atrial flutter and usually will not recur. The only thing to remember is to make sure that this patient does not have an accessory pathway, because this is a predisposition to atrial flutter in the first year of life. Usually when converted, whether by overdrive, whether by DC, they usually do not recur, and even medical prophylaxis is under discussion. Similarly, mobile left ventricular thrombus would be a contraindication to left ventricular ablation. The presence of a mechanical prosthetic heart valves are generally not crossed with ablation catheters. Female adolescents of reproductive age should not be exposed to fluoroscopy if any possibility exists that they are pregnant. Alternative energy source are being investigated. We are actually using now the cryoablation, particularly for the anteroseptal accessory pathways very near to the AV node, with the great advantage of reversibility before confirming the ablation. Research is also focused on developing better methods and tools for catheter ablation of ventricular tachycardia with structural heart disease or even VF. Epicardial ablation is being done now. For those who are very small, those who are younger than 4 years, less than 15 kilograms, we have concerns. The first concern is that radiofrequency lesion formation in immature sheep myocardium, similar to that in adult sheep myocardium acutely, but is associated with late lesion enlargement and fibrous tissue invasion of normal myocardium. So the lesion at first is the same, but later on results in a greater area of fibrosis. So as much as possible, we try to avoid ablating the very young and very small children. These observations may have implications for clinical RF procedures in infants and avoidance of RF ablation, if at all possible, in the first 2 years of life. Second, non-specific catheter and tools exist for the pediatric population. Currently available catheter, the minimum is a 5 French for non-irrigated RF tips. And curves are in general too large. This is particularly limiting in small children. Commonly, when the child is, let's say, 30 kilos or more, we are more, let's say, optimistic about the success. Finally, the experience of the operator and the center is crucial. Small patients requiring ablation should be referred to experienced reference centers for treatment. The number of catheter used and procedural radiation times should be minimized in these growing bodies. Electroanatomical mapping systems are most valuable in this setting. An important consideration in children is the sports participation in the presence of a pre-excitation. For the presence of premature atrial beats with no symptoms, structurally normal heart, they are eligible for all sports. For the AV reciprocating tachycardia or atrial fibrillation in the context of WPW, ablation is mandatory. Sports are allowed 1 month after ablation if there are no recurrences. For asymptomatic ventricular pre-excitation, the issue of much debate, ablation is mandatory if the patient is at high risk. Better safe than sorry. Sports are allowed 1 month after ablation if there are no recurrences. For those with paroxysmal supraventricular tachycardia, AV nodal reentrant, AV reciprocating tachycardia over a concealed accessory pathway, and atrial tachycardias, ablation is recommended, and again, sports are allowed 1 month after ablation. If the ablation is undesirable by the parents, the patient, or not feasible for a reason or another, they're still eligible for sports, except those with high intrinsic risk of loss of consciousness, contact sports, for example. EP and radiofrequency ablation is first choice in most SVTs if the child is more than 15 kilos and more than 4 years of age. Thank you. Any questions?
examples من السبورتس اللي بتوع وائل من الحاجات اللي احنا بنسمعها في الجرايد، هل انت بتحذرنا من حاجه زي كده او الاكزامبلز اللي عمالين نسمعها في الجرايد؟
والله from the cases I've seen, يعني I can remember one case. The parents were doctors. The aunt was the head of the anesthesia department, and I came with an adolescent female. She was 12 years old, and she was having syncope, and she had a long QT. And I discussed with them and with the aunt and that she needs an ICD and this is very dangerous, but they totally refused the idea of either intervening or screening the rest of the family, or they did not want to do anything. And during the revolution, her sister died suddenly while asleep. Her sister. They heard pistol shots. The sister died. And then they considered that they should be doing screening and doing other things. Another one was a basketball player in Alexandria, but they responded and everything went well. Yani she had syncope. The parents felt the grave situation and they responded and everything was done and she was free afterwards. Dr. Peter was presenting last time, let's say, dangerous case where he let the child resume sports after having syncope, and he was confident to do so. I will not be that confident. anything? يعني it will be يعني there will be doctors who will say not to intervene, and I have seen for example Professor Nadir Saoudi not intervening in patients like this, but I will let the decision be the parents' decision. Put the data in front of them. There is a risk of sudden death, particularly in the presence of a family history of sudden death, and that the procedure itself is a safe procedure with very high success rate, over 90%, and we do not have to run into this risk, but it's their decision.
What would be your very short message in 2 sentences to the young doctors regarding the arrhythmias in general? What would be your advice, bullet advice?
The most important thing is to consult and refer. Whenever you see something that you're not fully aware of, either consult or refer. And EP ablation, EP test study, and RF ablation is available for almost anybody over 4 years, almost most forms of arrhythmias, and it's a cure for life, avoiding medications, avoiding surprises, avoiding risks. That's it.
Any question from the floor? I think we should finish our first session and the opening ceremony. Now, Professor Dr. Ahmed